Welcome to the Rocky Mountain MS Center's webinar series, Maximizing Lifelong Brain Health in MS. Today's topic is what is PML? This presentation features Dr. Anna Shah, an MS Fellow at the Rocky Mountain MS Center at University of Colorado. Dr. Shah was born and raised in Chicago, Illinois. She attended the University of Missouri, Kansas City for both undergrad and medical school. She went on to complete her neurology residency at the University of Michigan, where she served as chief resident in her final year. This webinar is scheduled for approximately 1 hour. The first 40 minutes will be the presentation. If you missed something on a slide, we will be archiving this webinar on our website, mscenter.org, so you can replay it at any time. We'll reserve approximately 15 minutes at the end to answer questions from the audience. You can submit questions at any time during the hour by typing them into your chat window on your screen. We will answer as many questions as time allows. Today's presentation is for informational purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. With that, we'll turn it over to Dr. Shah.
Hi, everyone. Thanks for having me. I'll do a little bit of a discussion about progressive multifocal leukoencephalopathy, or PML if you want to avoid that mouthful, in multiple sclerosis. So I have no relevant disclosures to this talk. And just to get familiar with some of the concepts that we're going to be discussing in this talk, here's a picture of a brain cell, also known as a neuron. What you're going to see on the right side of that picture is these light blue areas around a yellow core. The light blue areas are what we call myelin, and those are the areas that are injured in multiple sclerosis. The yellow going through, or the core, is called the axon, and that's the kind of the pathway that the information gets transported along. You'll see these circular blobs that are providing those light blue areas of myelin. Those are called the oligodendrocytes, and those are the cells that help provide myelin to the neurons. We'll chat a little bit more about why this is important for our talk in just a minute. In this picture illustrates just the basic principles of multiple sclerosis. What you're seeing as the pink circles with the surrounding blue blobs are immune system cells that are attacking the myelin, which is yellow in this picture. So some of the acronyms I'll use commonly in this talk are MS for multiple sclerosis, DMT for disease-modifying therapies or treatments that we use for the treatment of multiple sclerosis, JCV is the JC virus, and PML is progressive multifocal leukoencephalopathy. And we'll talk a little bit more about the JC virus and PML. So what are our learning objectives? First, I want to make sure that everyone understands what the JC virus is and what PML is. We'll chat then a little bit more about what the symptoms of PML are, how we diagnose PML, what the prognosis and treatment of PML is, and then we'll talk a little bit more about the specific multiple sclerosis medications that have been associated with PML. So the 5 thus far that have been associated or that we'll discuss are Tecfidera, Gilenya, Tysabri, Rituximab, and Ocrevus. So first, it's helpful to get a little bit of history about how the JC virus came about. So we actually were seeing cases of patients that would have symptoms of demyelination ranging back to the 40s, but it wasn't until 1971 where they were actually able to identify what the virus was that was causing these symptoms. And that was identified in a patient named John Cunningham, and it turns out that that's what the virus is named after, so that's why it's called the JC virus. It was not a common disease that was seen until the 1980s with the AIDS epidemic, when people started having abnormalities in their immune system and the way the immune system was functioning. And it wasn't until 2005 where the first case of PML was found in multiple sclerosis. And that case in particular was associated with the use of Tysabri. So what is the JC virus? So it's something called a polyoma virus, which for all intents and purposes isn't necessarily relevant to this discussion, but it's a type of virus that's primarily composed of DNA. Why that's important is because we're not 100% certain of how someone gets this virus. So the route of transmission is unclear. The two main thoughts as to how one gets the virus, either urinary or through the fecal-oral pathway. Now, we have significant difficulties in confirming how one gets this virus because usually when people originally get this virus, it's during childhood and tends not to cause clinical symptoms. So it's hard to identify exactly when and how someone got the virus if they're not demonstrating symptoms. So about 50 to 60% of the population is thought to have antibodies to the JC virus, meaning that they have been exposed to the JC virus at some point in time. There was a study done called the GEMS study, which was looking at how many patients had been exposed to the JC virus in multiple sclerosis in particular. And this involved 10 different countries that participated, and they looked at over 7,000 patients. And they found that the JC virus positivity was about 57.1%. We think that there is a trend to be more likely to be positive for this virus or have gotten this virus as you get older, which makes sense because you've been exposed or more likely exposed to more ways of getting this virus. So how do you know if you have the JC virus or if you've been exposed to it previously? So the easiest way that we do this is through a blood test, where we test for something called the JC virus antibodies. Now, this test has really evolved over time, but the test that we currently use here at the University of Michigan, or at the University of Colorado, and other centers across the United States, is by first testing for antibodies with something called an ELISA test. When you have the ELISA test done, there are one of three options that can happen. You can either be positive, negative, or indeterminate. And you'll see an index level that's associated with this result. So if you have a level above 0.4, that's thought to be positive. A level below 0.2 is thought to be negative. And if you're in between 0.2 and 0.4, then you're thought to be indeterminate. So if you're indeterminate, we'll go ahead and do a second part of that blood test, something called an inhibition assay. And once that's done, it can officially tell us if you are positive or negative. So what does it mean if you have JC virus antibodies? Well, in most people, having JC virus antibodies doesn't really mean much. However, we know that JC virus antibodies do not protect you against development of PML or help you get rid of the virus if you have PML, like we normally think about antibodies doing. Like I mentioned a little bit earlier, people tend to get the JC virus usually in childhood and tends to be asymptomatic, meaning it doesn't cause symptoms. However, where it really comes into play with our multiple sclerosis patients is that it can impact the treatment pathway that you and your neurologist may decide on for future treatment. So if you're JC virus antibody negative, do you stay negative? I think this is a really common question that we're asked in the multiple sclerosis clinic. If you're negative, you can still be at risk of PML because we think around 3 to 8% of people will seroconvert, meaning go from not being exposed to the JC virus to being exposed. And that's a figure that we say is kind of a yearly percentage. The other reason why people that are JC virus negative are still at risk of PML is because it's potentially a false negative, meaning that you actually do have exposure to that virus and the test just wasn't sensitive enough. And we think that rate is estimated to be around 2%. These above two reasons are the reasons why we in the MS clinic, if you're on certain medications like Tysabri, will routinely test you for the JC virus to see if you have any exposure to it. So let's take a little bit of a sideways step and talk about what progressive multifocal leukoencephalopathy, or PML, means. So basically, because it's such a long word, it does a really good job of explaining what the disease is itself. So it's a disease of the white matter of the brain that's progressive and in multiple areas. So essentially, it's characterized by widespread multifocal areas of demyelination or an issue with the myelin that we talked about a little bit earlier. So who gets PML? And I think this is a really important question. So PML is not something that's just limited to MS. Like we talked about earlier, PML can really affect anybody that has an abnormality in their immune system. So the AIDS epidemic, or individuals with AIDS, is somebody that we commonly think about as potentially at risk of getting PML. Other disease states where you can get PML include different types of cancers, particularly cancers involving a part of your immune system called a B cell. If you've gotten organ transplants, or if you're immunocompromised for any other reason. The risk of developing PML if you're JC virus antibody negative is about 0.07 per 1,000 patients. And we think that's because of the risk of seroconverting or becoming positive for exposure to the JC virus. Now, I do want to point out there's never been a case in a patient that's had 2 negative JC virus antibody assays, followed by repeat assays every 6 months. So that's an important thing to keep in mind. I put this on here mostly for information. I think this is probably a little bit beyond the scope of this talk, but just to have a little bit of information about how the JC virus itself causes this disease. We'll look a little bit at this picture. In the top left-hand corner, you'll see the JC virus particles, those little green blobs that kind of look like grapes. So what happens is the JC virus will actually attach to a receptor on the surface of a cell. It'll get internalized into the cell and actually make its way to the center, the powerhouse of the cell called the nucleus. There it kind of unwinds, reveals its internal structure called DNA, and will have its DNA replicated. And then eventually it'll reform more JC virus particles and eventually get released from the cell themselves and essentially killing the cell itself. So our JC virus causing PML tends to affect oligodendrocytes. If you remember that first slide that we were talking about, oligodendrocytes are the cells that provide the myelin for the neurons or the nerve cells. When these oligodendrocytes are killed, they lead to areas of demyelination. When demyelination occurs, you can actually expose the neuronal axons, or kind of those central wires, to injury as well, thereby causing a lot of our symptoms. So if you look at the area I highlighted with the box there, you're seeing disruption of that myelin, or that yellow outer coating, with subsequent exposure to the axon, or that orange rim that's going through the center. So what kind of symptoms does PML cause? So symptoms can be quite diverse, and as we alluded to earlier, because it can affect multiple areas of the brain, the symptoms vary depending on which areas of the brain are involved. So they can range from weakness to vision changes, confusion, personality changes, changes in how you walk, or clumsiness of your limbs. There do tend to be some symptoms that are seen more commonly with PML as opposed to other neurologic symptoms. So in a study, they kind of assessed what the most common things that they saw were. And so in this one study, they thought 65% of PML cases all had walking changes. About 60% had limb weakness, so meaning weakness of an arm or a leg. About 33% had changes in their thinking or memory or personality. 20% had vision changes. And it's important to note that these symptoms don't start abruptly, like not present 1 second and present the next, but they tend to progress over days to weeks. So how do we go about diagnosing PML? So historically, before we had the availability of certain tests that we do now, people needed to do brain biopsies for the diagnosis. So they would take a piece of brain tissue, look at it under a microscope, and confirm that the findings they were seeing in the brain cells were consistent with PML. However, now we can diagnose PML based on a combination of 3 things. The first is a clinical history. The second is neuroimaging, usually with MRI scans. And the third one is with a lumbar puncture or a spinal tap, where we gain access to some of the fluid that goes around the brain and spine. So let's talk a little bit more about the clinical history. So within PML in multiple sclerosis, we really need to make sure that patients are on a medication that's been associated with PML. And we'll talk a little bit more about those medications in just a couple of minutes. The other thing that's really important in order to kind of fit this diagnostic criterion of PML is you need to have symptoms that are consistent with PML, so symptoms similar to what we just chatted about. The second criterion is neuroimaging. So there are two different types of neuroimaging we usually think about, CAT scans and MRI scans. CAT scans tend not to be quite as sensitive because we can't see the brain tissue quite as well as we can with MRI scans. So we really rely more on MRI scans than CAT scans. What do MRI scans show? And this is a little bit more of logistics, and certainly don't expect anyone to understand exactly what this means. But we describe it as bilateral multifocal white matter hyperintensities. And I'm going to show you a picture of what that looks like in just a second. If dye or contrast is given to patients for these MRI scans, they tend not to show up bright with regular traditional PML caused by MS medications, and there usually tends to be not very much swelling around these lesions. We usually tend to see MRI findings before patients are reporting symptoms. So here's an example of what we might see on a brain MRI. So this MRI that you're looking at on the left is what we consider a normal MRI. And these are sections that we consider, if you think about sections going through your head horizontally with a person laying flat on their back and we're looking up towards their head, those are kind of the pictures that we would see. And so you see how the pictures from the right side to the left side in that left-sided picture look very similar. Now that picture on the right half of the screen is a picture of what PML may look like. So could I have you buy that the white, bright stuff is the abnormalities, and it looks asymmetric, meaning the things that we're seeing on the left half of the screen are very different than the right half, and that's something we tend to see more with PML. The third criterion for PML diagnosis is looking at CSF, or cerebrospinal fluid studies. And this is something we obtain by doing a spinal tap. Now, what we're looking for when we do this is we're looking for the actual DNA of this virus itself, of the JC virus. One of the things that we've really improved on dramatically over the years is we've improved on how many copies of the JC virus we can detect in a milliliter of cerebrospinal fluid. And this is really important because it helps us make the diagnosis earlier, meaning that we don't need to see large amounts of DNA in order to detect it. We can detect it with lower levels. And we will hear about how if we make the diagnosis earlier, it tends to do better for outcomes. So what exactly are the outcomes of people that acquire PML? So we will focus just on MS patients that acquire PML in this instance of this talk. So in those that have iatrogenic immune suppression, which basically means you're on a medication that's been known or can cause PML, the survival tends to be around 75 to 80%. In those that survive the PML associated with the medication Tysabri in particular, which is the medication that we use in MS that has the highest rates of PML, there is thought to be significant disability in those that survive, and it's thought to be around 2/3 of patients. So it's certainly something that is very important for us to recognize and think about when we're deciding on treatments and monitoring treatments. Are there any treatments for PML? So there have been a lot of therapies that have been tried, but unfortunately nothing to date has been proven to be effective. The most important thing for us to do in multiple sclerosis patients, if we suspect PML, is to remove the medication that we suspect is causing or putting someone at risk of it. In Tysabri or Natalizumab, we do something called plasmapheresis, which is very similar to dialysis, where we remove the medication from the blood itself. There have been lots of different treatments tried, So if you remember that picture we were looking at earlier about how the JC virus enters a cell, there has been research looking into things that stop the virus from getting into the cell, from getting out of the cell. But unfortunately, none of those have been super effective. However, there was a recent publication in July 2019 that talks about this potential immune checkpoint blocking antibody that's been helpful. And what this means is it lets the immune system fight the JC virus infection. But I think we've still got a lot more research to do about that, but something on the horizon. So let's dive right into the different treatments, talk about what we know about the PML cases associated with these different treatments. So the first one we'll talk about is dimethyl fumarate, or Tecfidera. For the sake of the rest of these medications, I'll use the brand name, so I'll refer to it as Tecfidera. So there have been over 400,000 people treated with Tecfidera in the world, and that equates to over 780,000 years of patient experience. So as of September 1st, they have reported a total of 7 cases of PML. Now, really important things to note for these cases of PML is that they've never been on Tysabri, and you'll hear me mention this quite a bit throughout the presentation. They have not been on any other medications that suppress or change how their immune system functions. And they don't have any other medical conditions that could result in a suppressed immune system. All 3 of those things are very important because they could serve as confounders or other reasons other than medication why someone might be at risk of PML. So of the 7 cases that they reported, they did find a common thread where the white blood cell called a lymphocyte was low. So 6 of the 7 cases had moderate to severe lymphopenia, and I'll explain a little bit about how we classify lymphopenia in just a second. While the 7th case had mild lymphopenia. The ages of the patients that developed PML range from 54 to 66, and 1 of those 7 cases was fatal. It is worthwhile to note that that white blood cell, the lymphocyte count in that patient was low for about 3.5 years, which is a pretty long period of time. When we talk about lymphopenia, and this is probably something that you'll see on blood work that's done with your physician if you're on this medication, we categorize something as mild if your lymphocyte count is from the lower end of normal to about 0.8. It's moderate if it's between 0.5 and 0.8. It's severe if it's 0.2 to 0.5, and then life-threatening if it's less than 0.2. So if we go back to the cases that had PML on Tecfidera, we said most of them were moderate to severe, so between 0.5 or 0.8 and 0.2. So circling back, risk factors other than the prolonged low lymphocyte levels in Tecfidera are thought to be an age greater than 50 as well. So the recommendation that the company that produces Tecfidera says is that you should consider stopping or interrupting the Tecfidera if you have severe lymphopenia that has been persistent for more than 6 months. And again, this is a level less than 0.5. So now we'll move on to Fingolimod, or Gilenya. Now for Gilenya, there have been more than 290,000 people treated worldwide with about 714 years of patient experience. As of the end of August of this year, there have been a total of 30 cases of PML reported on Gilenya. Again, similar to what we talked about with Tecfidera, none of these patients had been on Tysabri before. They had not been on any other medications that could suppress or regulate their immune systems, and they didn't have any other medical conditions that suppress their immune systems. All of these 30 cases that have been reported were outside of the clinical trials, and of the 30, 3 of the cases have been fatal. So the rate of PML that we estimate on Gilenya, again with no Tysabri use in the past, is about 1 in every 9,800 patients. The drug company that produces Gilenya, Novartis, does not have any any sort of data on what the difference in these risks are if you have been on Tysabri in the past. So that's something we don't quite know. This is a nice chart that kind of describes one of the things that we presume is a risk factor for the development of PML if you're on Gilenya. So as you can see on the chart, as patients are older when they started the treatment, they are more likely to have acquired PML. So we think that's one of the risk factors we should take into consideration. Another risk factor to take into consideration with the development of PML while you're on Gilenya is how long you have been on the treatment. So again, if you look at this chart, you'll see those that have been on the treatment for a longer period of time were more likely to develop PML. Okay. Now we'll segue a little bit into Tysabri. As I've been alluding to, this is the medication that we really, of all of the MS medications, has really strongly been linked to PML. So there have been around, just over 202,000 patients treated worldwide with this medication, with over 765,000 patient years of exposure. Now, there have been, as of the end of August of this year, a total of 825 cases of PML, and 822 of those cases were MS patients. 3 were Crohn's disease, which is another indication for Tysabri. Now, because there have been such a significant amount of cases of PML on Tysabri, we do have better information about what it is that puts one person at higher risk of PML compared to others. So the 3 risk factors that have been very strongly associated is, of course, having the JC virus antibody and having more of those antibodies, being on the treatment for a longer period of time, particularly past the 2-year benchmark, and having used an immunosuppressant medication in the past. Now, the doses that individuals got in terms of how many Tysabri doses before they were diagnosed with PML varied quite a bit, from 8 to 148 in these cases. However, the average fell just around 51 months. So this is a chart that a lot of us as neurologists use to estimate the risk that individuals are at if they are started on Tysabri. So you can see the 3 risk factors that we kind of talk about make up the 3 different columns. So whether you have the JC virus antibody, whether you've been on immunosuppressants in the past, and how long you've been on Tysabri. And so those are 3 different branching points that allow us to kind of quantify what the risk is for each individual patient. I'm going to move on to the next slide because I think it helps demonstrate the risk in just a more detailed way. So if you recall back at the beginning of the presentation, we talked about how we're tested for the JC virus through that blood test. So when you get an index value telling you that you are at this number, it can actually help you quantify your risk a little bit further in terms of development of PML on Tysabri. So for example, looking at this chart, if we said, I am a patient who has been on Tysabri for 4 months and my index value of the JC virus antibody was 0.7, my risk is about 0.01, which is considerably less than if my index value was 1.7, where my risk would be 0.2. This chart here demonstrates the rates of PML in Tysabri. So you can see as it starts in December of 2009 going through December of 2017, there was a very steady increase in the amount of patients that developed PML on Tysabri. The introductions of the green arrows are the developments of different JC virus antibody tests that we had. And you can see really since somewhere between 2015 and 2016, the level has really, or the amount of PML cases has really leveled off with better testing and better knowledge of these risk factors. The prognosis of patients with Tysabri is a little bit better understood, again, because we have more cases and more information. About 76% of patients diagnosed with PML on Tysabri were alive at least 6 months after the diagnosis. Things that we think are associated with improved survival if you acquire PML on Tysabri is a younger age of diagnosis, less functional disability before you were diagnosed, a lower JC viral load at diagnosis, which kind of plays into the importance of being able to detect lower JC viral amounts in the fluid around our brain and spine, and then also having more localized brain involvement in your MRI at the time of diagnosis, meaning that there aren't quite as many areas involved. The next medication we'll talk about is Rituximab or Rituxan. Now, I do want to say that this medication is not officially FDA approved for multiple sclerosis, so our information is a little bit more limited. I do bring it up because it is a common medication that our patients are on, so I think it's something that a lot of people are interested to hear about. Now, there have been no cases of PML in MS patients on Rituximab. However, there have been PML cases reported on Rituximab in other patient populations. Now, the ones that have been reported are typically things like lymphoma, rheumatoid arthritis, and lupus. And we estimate that risk to be somewhere around 1 in 30,000. Now, I do want to bring to light the fact that most of those patients with those other disease states are on multiple medications that affect their immune system. So as we talked about earlier, being on multiple medicines that affect your immune system can increase your risk of PML in general. So that is an important thing to note, whereas compared to our MS patients on Rituximab, they tend not to be on multiple medications that mess with the immune system. And then this is the last medication we'll talk about, which is Ocrelizumab or Ocrevus. So there have been over 130,000 patients treated, less than our other numbers in some cases just because it is a newer medication. As of September 30th of this year, there have been 8 cases of PML reported in total. However, the really important thing to note, which we'll talk about in more detail, is that 7 are thought to be carryover cases. So what is a carryover case? Those are defined as cases where MS patients had symptoms that may have been typical for PML before starting Ocrelizumab, and they were previously on medications known to cause PML. In these cases, 6 of them were previously on Tysabri, and 1 was previously on Gilenya. However, we put it under the Ocrelizumab box because these patients were officially diagnosed with PML when they were on the Ocrevus itself. Now, of these 7 carryover cases, none have been fatal to date. Now, the one exception to this is there was a PML case in a 78-year-old patient in October of this year, so fairly recently, and this patient was not previously on any medications known to cause PML. What we do know about this case is the patient had low levels of a type of white blood cell called neutrophils, and this case was ultimately fatal. So it is important, I do want to highlight that there was one case that we know about of PML in Ocrevus patients where we can't identify they were on medications previously, but this is the one single case we know about. All right, and with that, I will turn it back over to Kelsey, I think.
Awesome. Thank you so much, Dr. Shah. If you have a question to submit, please do so now during using the chat window on your screen. We don't have any questions submitted quite yet. I want to just thank you for your time and all that preparation that you put into this. I will say if you have further questions, you can email them and we can see about getting them answered in the future to education@mscenter.org. Thank you.